So as we get started, I'd also like to thank the Oliver Center for providing videotaping. And if you go to our website, on the UTMB website, on the Lunch Bunch, you'll see video archives of our previous topics. And they're there if you missed a day, couldn't come in, but also if you came and just want to review some of the information that you obtained that day, it's really a great resource. Wonderful. Well, I'd like to get started. Can everybody see? Okay. So the bathroom key, we're going to talk, honest talk, practical solutions for incontinence in men and women. So how common is incontinence in women? And we see that for women aged 40 to 60, so I think that's really young, 40 to 60. Very young, just babies, right?
Now that's a real baby.
That's my baby. She's my baby girl. I know, see,
And so is she, but I can't believe that she's your daughter.
Well, I had to bring her today because Dr. Sonstein showed a picture. He's going to show you a picture of his daughters. I just had to try to outdo them, and I have one in living flesh here. And she comes every month. So, one in five aged 40 to 60. And then it doesn't get better as we get older, right? We're all finding that out. So it's even more common as women get older. It's 1 in 3 will have problems with incontinence. And when we say urinary incontinence, it sounds like it's a, one type of thing. But it's kind of like dogs. There are a lot of breeds. You can have a Chihuahua or you can have a Great Dane. And incontinence is a mixed bag as well. And so you can have stress incontinence. Does anyone know what stress incontinence is? Well, Angie, I'm so proud. Angie works with us in our clinic.
So we hope you know then, right?
Anybody else? Stress? Is it because you're like really stressed and so your bladder leaks?
No, isn't it when you cough or sneeze or something like that?
Yeah, so it's when you cough and sneeze and you put abdominal stress, bouncing on the bladder, and then the urethra doesn't hold up on the job, right? And then urge incontinence, does anybody know what that is? No, like the next.
Isn't that when you really think you need to go? You may not go that much, but I've got to go now, and if I don't go, I'm going to wet my pants.
You're exactly right.
Okay.
Exactly. So that can be, from a variety of triggers, right? You can, I think the bladder can grow eyes and ears. So it can see the toilet and go, okay, let's go now. I'm there. And you don't have your pants down yet, but she saw the toilet, right? Or she can hear the running water and she goes, oh yes, that sounds wonderful. And then starts going. You're like, wait a minute, no, not yet. So that's urge. And you can have a mixture of stress and urge, and that's called mixed incontinence. Okay? Overflow, and that's when your bladder gets so full, but you're not emptying completely, and so it just can't hold anymore. So with any little thing, like any little bit of stress or just a bladder spasm, it starts to leak. And transient is usually when you have a bladder infection. So your bladder's really irritated, it starts getting more, urgency, and it can kind of make you have incontinence, but once you treat the bladder infection, it resolves. So when we're in the exam room, what I need to do is put my detective cap on, right? And I have to try to figure out what's going on. Is it stress incontinence? Is it urge incontinence? Is it a mixture of both? Are you emptying your bladder okay? All of those things, I gotta just try to, get it all figured out. We'll cover primarily today, since we have limited time, the 3 most common causes of urinary incontinence. So that's urge, and then a mixture of both. incontinence, again, that's when you're active, you're running along, and with each step, you might be leaking a little bit as you go along. You might notice this pose. So you cough, sneeze, anything you expect might cause the leak. The legs start to cross, right? And I love this. I laughed so hard, tears ran down my legs. That is clever, right? And I don't want anybody to hold back from laughing so hard. That's the best medicine in the world. And what causes stress incontinence? We blame on big-headed babies. Alexandra had to have an ultrasound when she was a baby because her head was so big. And so when those big-headed babies come out, you can imagine that with the urethra, that would cause some damage for the underlying support, right? And also people that put a lot of abdominal pressure down kind of on a constant basis with smoking, coughing, kind of that chronic cough, they're going to be more symptomatic from that lack of support of the urethra, and so they'll leak more frequently. I see a lot of people come in that said, okay, my allergies started back up, I'm coughing all the time, I got to get this taken care of. They might be just fine about 8 months out of the year, but those 4 months are miserable that they're suffering from their allergies. So chronic cough, and then unfortunately aging. Yeah, we lose that connective tissue support. The muscular support also gets less robust, and we can leak more frequently. So I'm here to tell you size matters, okay? For stress incontinence, size matters. So men don't have as much of a problem holding on to the bladder contents with increases in stress and strain as women, because we've been blessed with this very short little stubby urethra, and men, there's at least a foot long, right? And so with that short little stubby urethra that's trying to hold back on a full bladder, you can imagine that there's a little loss of support that we might run into difficulties. So what can we do to regain that support if it's not there? Well, primarily we can increase that with some muscular tone of our pelvic floor to be a backboard of support. One of the best analogies that I have with how the urethra functions and with a lack of support is if you take a garden hose and you're running water through the garden hose, right? Everybody picture that? Now take that hose and lay it over the sandy beach in Galveston. And now I give you the job of trying to stop the flow of water through that hose by stepping on it. We may or may not be successful, right? Because we've got a sandy backboard. Now I give you that hose, you're running the water through the hose, it's pouring out the other end. And I have you lay it over your driveway. And I say, now go ahead and step on it and stop the flow of water through your hose. Do you think you'd be successful in doing that? Yeah. Because you've got that good backboard of support. So now with an increase in pressure on your hose, you're going to kind of compress it between that pressure and the driveway. So we want to increase that backboard of support either with muscular tone or we can sling it up. I mean, we're in Texas, we might as well sling things up, right? So the sling actually puts a backboard support that's not under tension on the urethra. So stress incontinence, we need to regain support, but overactive bladder is a separate problem. And that urge incontinence, that the bladder that's grown eyes and ears. And that comes along with a symptom complex. And you get that urgency, and that's key to overactive bladder and urge incontinence. You get that urgency, and you may or may not make it in time to empty your bladder. Often people are going more frequently because they're thinking about their bladder more often. They get that sense of urgency that's driving them to the bathroom, even if their bladder's not full. And so they're going more frequently. They're often waking up several times a night to get up and empty their bladder, which I think is really difficult because if you're waking up several times a night, every night, it'd be like if your phone rang in your bathroom and you had to get up 3 or 4 times a night to answer your phone. How many people would get tired of that? We would all get tired of that, right? But that's what overactive bladder is like. So it certainly is something that we want to try to grab the reins of, rein that bladder in, and take control rather than have her give us, a lot of senses of urgency. So often people that have overactive bladder or urge incontinence will feel like this. They can tell me all the good bathrooms between here and Galveston or wherever they live. And they were so excited when Buc-ee's came into town, right? So, let's just sign, right? It's only 262 miles to Buc-ee's. You can hold it. I saw another one this weekend, and unfortunately I was driving, so I wanted to pull over and take a picture. And it said, Buc-ee's at the next exit. You're in luck, but you are Miami. Very clever. So with overactive bladder, the risk factors, things that kind of can kick it in, again, if you have a bladder infection, that's going to send your bladder kind of being irritated and give you some senses of urgency. As we get older, again, overactive bladder urge incontinence becomes much more common. Some neurologic problems and anything that affects any nerve between the nerve going to the bladder, the spinal cord, or the brain can cause problems with urgency, frequency, and overactive bladder. So things that cause problems with some of our peripheral nerves, common thing that a lot of people have and can be more common as we get older too is diabetes. So that can affect our nerves, and we see people that have overactive bladders, and we even see if they've had it for a long time, they can get into retention and not empty well. Things that affect the spinal cord, so people with spinal cord, traumatic injury, they can have overactive bladder. Also, multiple sclerosis can cause overactive bladder. And things in the brain. So we can affect a number of things in the brain. One, we can just have, dementia or a stroke that makes it so we don't really care if we make it to the bathroom in time. And other things that actually trigger us to go more frequently. And bladder irritants. And I know Carla will get into some of the bladder irritants. Can anybody tell me what a bladder irritant is? Something that's going to cause us to go more frequently? Caffeine, yes. Definitely caffeine. So here's our little ladies with their caffeine. And I can, tell people they've got to exercise, lose weight. And I said, oh, and you need to back off on your caffeine. My caffeine? I can't do that. So people can be fairly tight-gripped on their caffeine. So to treat that, what we do is really ask you to kind of try to back off on some of the bladder irritants. And really first line is to send people with overactive bladder to our wonderful physical therapy people. And it's not just a general physical therapist. These are physical therapists that have gone through extensive training to be able to help with incontinence and work on the pelvic floor. Medications. Can anybody name a medication that you might use for overactive bladder? Yeah, oxybeno, Detrol. So you see a lot of commercials these days for gotta go right now. They just start, calling you. We can put Botox in a lot of places, right? We can put them in our foreheads, find those little, crow's feet or whatever, and Botox them. How does Botox work? Why does it? It paralyzes the muscles. Instead of walking around with your forehead all contracted, it's just really a mellow forehead and there aren't any wrinkles there. And And so you can do that with the bladder too, so you can calm down the bladder spasms that are sending you running to the bathroom with some Botox. Nerve stimulation can be obtained in a variety of ways. One is posterior tibial nerve stimulation, or PTNS. And that, again, talks to the nerves that go to the bladder, and it kind of runs up through the leg nerve and then goes to the bladder nerve. Or you can do a sacral nerve stimulation too. These are for kind of refractory cases. There's that wonderful Botox and stimulating those nerves. So just to summarize some of that mixed bag of incontinence, for stress incontinence, you just need to find that backboard of support. Lay a driveway, right? We're not going to actually do it with concrete in the vagina, but, you know, maybe good muscular support. So maybe we're going to do concrete. Not quite yet. Okay. Urge incontinence, we want to treat those bladder spasms. And to do that, we can get you in with Carla, our physical therapist. Medications, if that doesn't work, a little Botox, and we can talk to the nerves through PTNS or SNS. And if you have mixed incontinence, again, that's a little of both, stress and urge. Then what I want to do is put my detective cap on and try to figure out what's bothering you the most. The leak with cough and sneeze, or the leak with urgency, and start there. So with that, I'd like to hand it over to Dr. Sonstein as he addresses the male component.
Some males in the audience, that's great, and I know the rest of you guys probably maybe are getting woken up in the middle of the night perhaps by your counterpart getting up to go to the restroom. So hopefully everybody will have something to gain from my talk. So without further ado, and thanks again for coming out on this kind of grungy day. So thanks again. I wasn't expecting such a great turnout. So first of all, we already had a little anatomy lesson from Dr. Muir, but I'm going to go back to that. We're going to talk about incontinence, but also a broader spectrum of symptoms that's more common in males, and we call it lower urinary tract symptoms, or BPH, or benign prostatic hyperplasia, is another description of these symptoms, and we're going to get into what these are. But first, a little anatomy lesson. We already talked a little bit about the long urethra, and around that urethra, just as the urethra exits the bladder, is the prostate gland, okay? And it's literally like a donut, and through that donut hole goes the urethra. Okay, so as the prostate grows, which is a normal part of aging, that urethra can be constricted. Okay, and that's another reason why men generally incontinence is not as common as in women, but they can get lower urinary tract symptoms, and we'll talk more about what those are. Now, stress incontinence, which we've all learned what that was already from Dr. Muir's great talk. Stress incontinence can occur in males. It's usually a result of some sort of something I did, some sort of surgery on the prostate. So if we remove the prostate for cancer, or if we operate on the prostate, I'll actually show you what that looks like, to open it up to relieve symptoms. Sometimes we can do too good of a job, and stress incontinence can be the result. Other than that, we don't see a lot of stress incontinence in males, so it's not going to be a huge portion of what I talk about today. Now, urgency and urge incontinence, certainly we can see as a part of this, these lower urinary tract symptoms that are most commonly caused by an enlarged prostate. So here's our normal anatomy. We have a bladder. It squeezes. It pushes the urine through the urethra, through the prostate, through the rest of the urethra, and out the tip of the penis, okay? Now, when the prostate gets too big, as we can see here, it's enlarging, it's pressing, it's compressing on that urethra. The bladder has to work harder, and as you can see by the picture, maybe not all the urine gets out every time. The bladder doesn't do a good job of emptying. Which brings me to another, something I always think about, the bladder is really an amazing organ if you think about it. We probably don't give it enough respect, or at least as a urologist, I don't think we give the bladder enough respect. What does the bladder do? It collects, or it stores. What else does it do? When it's time to go, it empties. It does two completely opposing tasks, and a lot of the times it does it very well. So it stores, and when it's time, and it holds, and when it's time to empty, it empties. Does two completely opposite things, and usually it does them quite well. But when those things get out of whack, that's when we get involved. But just something to think about. So respect the bladder. I'll get off my soapbox. So when we have prostatic enlargement, which most men have, you get old enough and the prostate grows. Some men, it grows more than others, and in some men it causes more symptoms than others, really regardless of size. But basically, if you take a man's age, that's about the frequency or the incidence of benign prostatic growth, okay, in that man. So if you're 80% of men that age will have prostatic enlargement. If you're 40% of men, okay? It starts to grow around the 3rd or 4th decade of life. So what kind of symptoms are we talking about here? Well, we break them down into 2 types of symptoms. First are the obstructive symptoms, okay? That's going to be the straining to urinate, using the abdominal muscles to push out the urine, stopping and starting, dribbling, having the sensation that you're just not able to get all that urine out. So those are obstructive symptoms. And those symptoms are a directly caused by the enlarged prostate. They're literally cutting off that, if we use the hose analogy that Dr. Muir gave us, it's literally cutting off that hose, okay? Irritative. This is very similar to the urge incontinence type symptoms that we've already heard about. So irritative symptoms are not a direct effect of the prostate blocking the urethra. The irritative symptoms are a response of the bladder to the obstruction. So the bladder gets thicker. That in turn causes it to have less capacity. And that in turn causes the muscle contractions. It's just like any other muscle. It's working out, right? It's lifting weights by having to push that urine out. So it gets stronger. So irritative symptoms are very much like the symptoms we've already talked about when we talk about urge incontinence. Frequency, urgency, getting up at night. That's probably the most common reason that men come in to see me, is because they're tired of getting up in the middle of the night 3 or 4 times to go to the bathroom. Those are all irritative symptoms, and that is the bladder's response to the obstruction from the prostate. And interestingly, many of those are treated in exactly the same way that you've already heard about in Dr. Muir's portion. So we have the symptoms. They're very common. We've already talked about that. When do we decide to treat this problem? Usually, luckily, it's not an emergency, okay? Only about 2% per year in all men who have prostatic enlargement, only about 2% per year are going to develop some sort of emergency, some sort of medical problem from this, okay? And that's the inability to urinate, so can't pee. That's a problem, right? So we have to put a catheter in and at least acutely, and then sort things out. Bleeding, urinary tract infections. Those are all the things that we get excited about, because those are medical problems that the enlarged prostate is causing. Luckily, that doesn't happen very often. More often, it's this kind of emergency, okay? It's annoying. It's affecting quality of life. I can't sit through a movie. I can't sit through a ball game. Every time I go somewhere, I'm scouting out so I know where the bathrooms are, okay? And this is by far the more common presentation, okay? So there's no medical problem. It's not hurting the kidneys. There's not infections or bleeding, but it's annoying and it affects quality of life, okay? And we're very interested in improving quality of life. So either if we have medical problems from the BPH, obviously we're going to treat it, or if it's affecting quality of life, we're going to talk about treatment options as well. Okay. Generally, we start with medical treatment. Okay, medicines, and this has really exploded in the past 10 years or so. It used to be we basically had one medication or one type of medication to give for this problem, and that medication, that class of medication is called an alpha blocker. And what an alpha blocker does is it blocks nerves that tell smooth muscle to contract. And that there's smooth muscle within the prostate gland. And so if we block those nerves, the smooth muscle relaxes and it literally will open up that channel a little bit, or it'll help with that obstruction, okay? And so alpha blockers are really good for obstructive symptoms. They improve flow, dribbling, straining, they help men empty better, and they're very effective, okay? There can be side effects. Dizziness with standing is a common one, stuffy nose, and it can cause some ejaculatory dysfunction as well. 5-alpha reductase inhibitors were the next type of medication that came onto the market, I think in the late 80s. And those will actually shrink the prostate. It takes a long time to work, up to 6 months to 12 months to actually have an effect, but those will actually shrink the prostate by blocking an enzyme that converts testosterone into an active form within the prostate. And this one, if you watch TV, you've seen the commercials. I use the generic of tadalafil, but this is Cialis, okay, which was developed as a medication for erectile dysfunction, okay, for sexual dysfunction. But they found out that men who took it also said, hey, you know what? In addition to helping with my sexual dysfunction, I'm peeing better, which is awesome, right? So what they started doing was testing it in men who had both erectile dysfunction and lower urinary tract symptoms, and it worked. In placebo-controlled trials, it's better, okay? So this one, you can kind of kill two birds with one stone by taking a daily dose of Cialis, and it's helping with the urinary tract symptoms and with the erectile dysfunction. So that's a popular one. Anticholinergics, we've already heard about those. That's the Detrol and the oxybutynin that we talked about when we talked about urge incontinence. Same medication. This obviously is going to be used to target those irritative symptoms, the frequency, the urgency, the getting up at night. Okay? It used to be a big no-no to give anticholinergics to men because it was thought that it would cause urinary retention, meaning that the inability to empty the bladder. And what we found out is in men who are carefully selected, that's just not the case. The chances of that happening is very low, but we do have to watch out for that. And then newest on the market in this arena is Mirabragon, or Mirbetriq is the trade name, and it works similar to the anticholinergics, but it has a different mechanism, and so it doesn't have the side effects of the dry mouth and the constipation, and also mental status changes in the elderly that we can see with the anticholinergics. Yes, sir.
Where does Avodart fit in there?
Avodart is a 5-alpha reductase inhibitor. So it's the one that shrinks the prostate over a period of time. So that's, and the two, since we're talking trade names, is Avodart, and the other one is Proscar. Those are the two 5-alpha reductase inhibitors. Interestingly enough, a side effect another effect of 5-alpha reductase inhibitors is hair growth, because that same enzyme that it's blocking also leads to male pattern baldness. So Proscar, or finasteride, is marketed at a lower dose as a medication called Propecia. It's the exact same medication, but it's a lower dose, and it's designed to prevent hair loss. So just a little. Well, no, mostly on your head, because that's where the male pattern baldness occurs. So, but yeah, so there's a little trivia there. So that can be a beneficial side effect as well of taking those, is you might decrease hair loss or actually increase hair on the head. All right, any other questions about medical treatment? It's a lot of stuff. Like I said, it used to be just one medication and that was it. And before that, surgery was very common. In fact, a TURP, which we're going to talk about, is the most common procedure that most urologists do. That's not the case anymore. So there's surgical treatments as well. And like I alluded to, the transurethral resection of the prostate, and we'll actually, so a transurethral resection of the prostate Oh, let me turn that sound off. Let's see. We actually go in with a scope, and through that scope we pass a loop, and we actually cut out the obstructing tissue. So what we're looking at here, this is the prostatic urethra. So this is where the urethra is going through the donut, okay? And we actually can go in, and this is through the penis, so there's no incision, and we literally are shaving that out, shaving out that obstructing tissue. There's another procedure called a, sir?
Doesn't hurt a bit.
No, it doesn't hurt a bit. No, it can be done under a spinal anesthetic. You don't even have to go to sleep. But yeah, it actually, believe it or not, pain is not a big issue after this procedure. There's just not a lot of nerves in there. A similar procedure, a little bit more modern, is called the laser vaporization of the prostate, and that it's basically a different means to the same end. In where we use a laser to vaporize this tissue, basically just melt it away rather than cut it out.
So when you cut that, where does that go?
Well, these little chips, these little shavings will go back into the bladder, and then when we're done, we'll go in there and we'll use a device called an ilic evacuator, and it'll suck all those little chips out. So that's...
Different type right there?
This is a little button, and we use that for hemostasis, basically. So that can vaporize. You see how it's sort of melting away that tissue? You can also use it to stop bleeding. So yeah, and it looks painful, but you know, I've never had it done, I'll be honest. But pain is usually not a big complaint with our patients that have this done. Side effects of that procedure: bleeding. Ejaculatory dysfunction can occur, so we have to counsel our patients about that, and incontinence. So that, remember I alluded to, there are, prostate surgeries can lead to stress incontinence. The incidence of stress incontinence after that procedure is less than 10%, but it's not zero, so we have to let our patients know about that. So we talked about surgical, laser ablation, I mentioned that. Physical therapy, which is a good segue into Carla's talk. Physical therapy that's relatively new on the urology scene as well, but it can be helpful for obviously for the stress incontinence for men who have had prostate surgery and who are leaking, so that they can strengthen their pelvic floors, strengthen their external sphincter muscles. But it can also be used in the either incontinence or urge type symptom spectrum, and so we utilize our physical therapists very often in that realm as well. So to summarize, the most common cause of urinary dysfunction in males is BPH, or lower urinary tract symptoms secondary to BPH, or prostatic enlargement, which is what we've talked about mostly today. The incidence of that problem increases with age as the prostate grows. It is infrequently a problem that causes medical issues like kidney failure, inability to urinate, bleeding, or urinary tract infections, but it very commonly causes bothersome symptoms that affects quality of life. And when that occurs, there are many treatments available: medical, surgical, physical therapy. And so mostly what I hope I've passed on is that if you have these symptoms, or your significant other has these symptoms, they're certainly not alone. And there's a wide range of treatments. We can be as aggressive or not aggressive.
Carla Czervenny, I'm a physical therapist, and I have some special training for pelvic floor physical therapy that will cover all these problems and some more for men and women. I don't know if I can treat men anymore after I saw those videos. I think but it works for both. Okay. The main thing that we hear, it's me and two more co-workers at UTMB doing pelvic floor physical therapy. So with the three of us, we have 5 days coverage here in Victory Lakes, and we have Texas City and Galveston as well. So that being said, there's no reason anymore to have a hard time with the bladder. And let's see if that comes up. If not, I'll just do by memory.
Maybe you could start by telling him, what are bladder irritants? I said coffee, but are there any other bladder irritants?
No. If you go to our clinic, we'll give you a list that's this long, and you say, might as well just give up and put the pants on and be happy and married. But the truth is, that list is huge. It will be chocolate, it will be apple juice and apples, there will be so many things. But what I tell my patients, most of all, 2 things. Caffeine and everything that has caffeine, not just the coffee, and also alcohol. That little drink, and that's not just for who has a bladder problem, that's all of us, okay? If we have 1 wine, we have that much, we pee 10 of that amount out, right? Why? What is a bladder irritant? The bladder irritant simply will make the bladder have more of that contraction. The bladder is mad and wants to get that out. Caffeine will do that, alcohol for sure will do that. But I tell my patients, I give them the list, I tell them to kind of watch. If those 2 things, I don't tell them do not drink that ever, choose your battles. What do you rather? Go to the bathroom 3 times a night and have a glass of wine? Or you rather sleep through the night and have that glass of wine once a week, once a month? So choose your battles, okay? We're here to tell you what would work, what would not, and the choices are there, right? So for sure, these 2 things will make you feel like crazy, okay? Now, what we hear the most when a patient comes to us from these great physicians is like, physical therapy for what? You know, that is the main thing we hear. Physical therapy for the pelvic floor. For women, for men. For kids, for my youngest patient ever was 12 for overactive bladder, and my oldest so far 98, okay? Right in between, I have had 2 that had no improvement, so it's easy. The good thing about the overactive bladder, that sensation of getting to my driveway, and now I can hardly get there, that is so easy to treat by using your muscles, and I will explain to you. Now, if you have the stress incontinence, the urge one, the one that you gotta go so bad, that will start work immediately, as long as you can find your muscles, which we will do together, and do the exercise correctly. Now, the other one that's due to the stress, either because of aging, change in hormones because of menopause, or maybe you had a baby, or whatever was the reason, or a surgical procedure for a man and now you lost that support that you had. That takes a little longer, but we are talking anywhere from 4 to 8 weeks to start going like, okay, this is getting better now, okay? So, what to do about the overactive bladder? What is that? Well, usually it starts as a problem. One day the bladder, which should work like this, it sits right here in our pelvis and should get urine from the kidneys, get to a certain level like a balloon. Imagine a balloon upside down being the neck of the balloon our urethra, okay? For the man a little longer than for the women. When it gets to a certain level of urine, it should be gentle, contract, and let you know you gotta go to the bathroom. The overactive bladder, instead of being gentle and just having a contraction, will throw you into a muscle spasm. And now that balloon that had a lot of room, even if it has 2 tablespoons of urine in there, it's gonna feel like it's about to explode, okay? So, since the bladder is a muscle sitting right here, and then we have the pelvic floor right under, like a hammock of muscles, if we do a little trick with these muscles here, maybe we can stop this bladder here from acting crazy and relax. Instead of that balloon just squeeze, now you can relax, keep going with life until you're actually full. And that's the trick. Learn the sensation. What is an urge? What is a fullness? That's relearning. Okay, the overactive bladder, for some reason, starts as a problem. We see variety of things that could have caused. I have had patients that was a UTI that caused. Others have been like that since childhood, the bad weathers or whatever. So whatever was the cause, what do? Nobody wants to pee on themselves. So we change our habits to kind of adjust to that crazy bladder. So now we're going to the bathroom just in case, which is a no-no. And we're teaching that bladder, whenever you want to go, just grab me and I'll run, okay? So don't do that, because imagine the overactive bladder compared to when you have a cramp on your leg, okay? Here you are, and then all of a sudden you have a cramp. Instead of stretching that cramp, you bend even more, that's gonna get worse, right? So the bladder, if it's overreactive and it's grabbing you and you're running to the bathroom, what is that gonna do? Grab you even more. By the time you get to the toilet, why am I here? I'm done, you know? So we're gonna learn a few tricks to manage that better, okay? Stress incontinence. Whatever reason, sometimes it started after childbirth 40 years ago and never went away, nobody talked about it, and now here you are at age 75, and that is worse, a little bit worse every year. Well, let's regain the strength of those muscles, let's work on that. Like I said, that will not be overnight, but with a good 6 to 8 weeks, we'll see improvements. Now, what I see the most with my patients that have the stress incontinence, what do? They go to the store, get the biggest pad there is, because nobody wants to be embarrassed in public and wet themselves. They put that on. What happens now? Okay, I have my pad on, I'm good. So the bladder fills up, gets to almost full, triples down a little, cuts the urge down. There it goes again, full, triples down a little. So the patient comes to us and I say, how many times a day do you go to the bathroom? 3, and at night, once. So why? Because that urine is constantly going to the bed, okay? So you don't even think about it. So now you're just going to the bed. Sometimes just putting a patient, asking the patient, okay, every 3 hours, I would like for you to go to the bathroom during the day. Go to the bathroom, sit and relax and try to pee. By the way, best position to sit and pee for women, and then I'll tell you about the men in a minute. For women, sit right here and relax, okay? Why? Anatomically, our urethra is more to the front. When we sit like that, those muscles relax better. With my guys, sometimes I do ask them to sit down to pee. That's for the ones that are having a hard time peeing for whatever reason. When they sit down, they don't have to engage the hip muscles, which could give them more of a hard time to pee, okay? But then I really negotiate with them, and I tell them it's just for a little bit, and some come back and say, you know what, it was not that bad. So that's the best position to pee, okay? Yes.
Can you show us the position again, because you were behind the table, we couldn't see from, thank you.
So the best position to pee would be just relax right here. And another thing, don't ever strain, okay? Don't ever. So if somebody has stress incontinence every 3 hours, with or without an urge, take a break, go to the bathroom, sit there, sit like here, pee, done peeing, don't strain to make sure you're all empty. You could go back and forward again. That's what we call double voiding. And why is that? Because when we sit like that, could kink the urethra a little bit. And those are the cases that when you get up, you think you're done, you get up, a little more dribble goes down. That dribble was just stuck in the urethra, and if you just do the back and forth, you're good. Okay? So these are the little techniques for this stress incontinence. Sometimes just by putting on a schedule to go pee, that's it, cuts the pads down by half. You know, so if you were changing 3 a day, now you can change 1 and be okay. Then we'll get in with the exercises and go from there and finish that to where either the patients can go without the pad or perhaps have a penny liner in place, okay? Now let's go back to the urge. what to do about the urge? If I have had very recent a patient that he came to me, a male patient with severe urge incontinence. Talking to him, you know, a lot of little things that I could change, and then when I got to, okay, what do you drink during the day? Oh, I drink water and I drink 12 cups of coffee a day. All right, can we cut that by half? Cut that by half, guess what? His bladder is normal now. So it's just watching those irritants, okay? Other things that physical therapy treats for the pelvic floor, just so you know, constipation, sexual dysfunction, pain, pelvic pain, but mainly the bladder because it's so easy to get better, okay? How to work with the overactive bladder. The overactive bladder could go to a spasm. Every patient could have a different trigger. Some would be the running water. The other, seeing a bathroom sign. The other, just the fact that I'm gonna go out of the house, I gotta go pee 3 times in 15 minutes to make sure I'm good to go. Find your triggers. See what could be that's throwing you off to have that spasms, and then what to do to calm down, which we're gonna do it right now. Okay?
I have a question.
Yes.
Can somebody with an implantable stimulator benefit from pelvic floor?
Absolutely.
Everybody can benefit from
Even
floor.
even with a stimulator?
Yeah.
When this person had caught a queen out 3 weeks and then had a stimulator, apparently improved about 40%. But can they go to therapy and perhaps even
Absolutely.
increase that?
I do have patients that do have this stimulator, you know, sometimes for a long time, sometimes new, and it's still, there is a lot, like I said in the beginning, there's a lot of habits that go along with incontinence that we can just change those little habits and we'll get better. And so just to wrap it up, and the 60% that's left can improve, okay? So sitting there, everybody now, I would like for you to do me a favor. Squeeze the muscles. So women, muscles around the vaginal opening. For men, the muscles that you would squeeze to stop the urine flow, okay? Before I forget, back in the day, the patients were told to practice this on the toilet. Well, now we know that's not a good idea because it's going to maximize the chances of having a confusion of the bladder. Okay, I'm sitting and I'm relaxing, and now you're telling me to stop. What do? I relax, I squeeze. What do I do? So don't do that, not on the toilet, okay? Prior to getting there. So everybody can find those muscles? Squeeze the muscles, hold for a little bit. Everybody? Yeah. Okay, relax. All right, those muscles that you squeeze and hold to hold the pee. Now we're not going to squeeze and hold them. Now we're going to do a little winking, just a flickering of these muscles, and that's what we call quick flicks. Okay. So I'm going to count for y'all to know the speed of this exercise. Muscles around the vaginal opening for the women. For the men, the muscles that you would hold the urine. Ready? Everybody ready? Okay, let's go. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. When to do this? This is the quick fix. This is the one that's going to work for the urge incontinence. The times that you're getting to your home and now the driveway is right there. When to do it? Before you get to that situation, okay? So you're leaving Victory Lakes today. When you get in your car, 10 little winks. Drive home. When you get near your subdivision, 10 little winks. Now you see the driveway is coming. When you park the car there, don't try to rush. Just sit there for a minute, for 30 seconds, 10 more little winks. How is that gonna work? So the bladder is in right here, squeezing you. That's what's giving you that urge. These muscles down here, the pelvic floor, are doing this number to the bladder, which is gonna make relax. It's like having a knot on our neck. Now it hurts so bad, what do? Massage a little bit, that relaxes a little bit. What happens then? If the bladder relaxes, now we have the time to walk to the restroom and calmly undress and get there, okay? If you have a case like, okay, now I'm calmer, I'm getting to the restroom, but now I see the toilet and it's coming. Well, walk in the bathroom and stand there as you do the little winking, undo your clothing, and then sit down and try to go, okay? Rushing, worst thing. If the urge is so strong that you cannot even do the little winking, doing nothing is better than rushing. That's going to get you to be, the chances of being dry is much better than trying to run over there. I think I covered most of what I wanted. Just one more thing. I do have patients that when they come to me, they're like, I already did these exercises, the Kegel, whatever they are, they don't work. The main thing that they don't work is because everybody thinks, okay, the longer I hold, the better for my muscles right here. And that's not true. It's like holding a grocery bag for a long time. You're walking around. When you let down, that arm is shaky, right? Same thing right here. So if we overdo it, instead of getting those muscles stronger, now they're very tired and weak. And when you need to squeeze and hold to get to the restroom, you got nothing left. Okay? Any questions?
That was awesome. Thank
I'm
you so
sorry
much.
for providing.
UTMB Health, working together to work wonders.